I start off with a picture of an apple and a pear because there's a Dutch saying saying that apples and pears might look alike, but they shouldn't be treated similarly, which is of course also true for osteoarthritis phenotypes. Maybe in the trials we've been performing so far, we've been treating apples like pears and the other way around. And the other point of this picture is that I would like this presentation to be a little bit juicy. So how can I'm not going to list up all the points that we arrived at after writing the article. So for more details and for looking at the recommendations and the framework itself, I would like to refer to this article. It's open access, so easily available. But I will touch upon the different points that we also described in the article, but a little bit in a different way than just summing up all the points. In this article, we used a panel, as I said, of 25 members with expertise in OA Phenotype Research. It was consensus-based, so we followed the Delphi exercise approach to provide a number of basic definitions and statements relating to phenotypes and OA Phenotype Research. Of course, the most basic important definition was the definition of a OA phenotype. The definition we arrived at is that OA phenotypes are subtypes of OA that share distinct underlying pathobiological and pain mechanisms and their structural and functional consequences. So a difference between men and women might be different phenotypes, but that's not necessarily so. So if you're doing phenotype research, in our opinion, you should try to look for the differences in the underlying mechanisms to see if there are different phenotypes. That's also clinically the most relevant thing, because that's the mechanisms you should try to affect to reach a positive treatment effect. And of course, all these things you are investigating, the phenotype is only relevant if it has any structural and/or functional consequence to the patient. Things that vary between patients but don't have any consequence for the patients are not very relevant. And there are different ways, there are different implications of having more knowledge about OA phenotypes. You should adapt your diagnostics to knowledge about OA phenotypes. You cannot diagnose an inflammatory phenotype if you do not do the appropriate diagnostics. Of course, a final purpose of knowledge about OA phenotypes is that you would like to perform targeted treatment. So an anti-inflammatory treatment for an inflammatory phenotype, an anti-resorptive bone treatment for a bone phenotype, and some phenotypes might also be more might best be treated surgically. And also for the prognosis, a phenotype might be relevant. Phenotypes with a worse prognosis are probably the phenotypes that require more intense treatment. And also when performing trials, it's thought that it would be good to enrich the trial populations by selecting those patients with higher rates of progression, so that it would become relatively easier to show a treatment effect of the tested treatment. So also enriching trials with appropriately phenotyped patients is a goal in itself. There are different approaches in finding these phenotypes, and I would like to give some examples of these. First, you can do analysis in existing observational cohorts. For example, the OAI cohort, and embedded in that is the FNIH Biomarker Consortium. Andrea Del Isola performed a phenotype research in this FNIH Biomarker Consortium. They did this by doing a systematic review analysis first to look for phenotypes that were quite consistently reported or investigated. They came up with a minimal joint disease phenotype, inflammatory phenotype, metabolic disorder phenotype, chronic pain phenotype, malalignment or biomechanic phenotype, and a bone cartilage metabolism phenotype. They looked for criteria to define these phenotypes within OAI. I don't want to go into detail, but I just want to show that they were indeed able to, in the end, in the last phase of the analysis, detect patients for every phenotype within the FNIH biomarker consortium. Another thing that I would like to point out is that 1/5 of this population showed complex NEOA, meaning that they fulfilled criteria for different phenotypes. This might be a hard category in clinics and a research setting, and might be one challenge in phenotype research, how to deal with phenotypes that overlap. Maybe a nice point for later in the discussion. This analysis was done using assumptions on forehand derived from a systematic review. Also, data-driven analysis are being performed now in OAI, and maybe we'll hear more about that later in the session. And I myself am also working on data-driven analysis on phenotypes in cohort hip and cohort knee, the Dutch cohort of very early hip and knee osteoarthritis patients. One obvious limitation of this approach is that these cohorts have a certain amount of data on a number of domains, pain, cartilage, bone, but the data you have is limited. The opportunity to get extra data are also limited. So if that particular cohort doesn't have so much data on the bone domain, you will not be able to identify that bone domain. So to solve that issue, you might decide to create a new observational cohort specifically designed for detecting phenotypes. And one big cohort of one big effort to do that is the approach cohort. In the approach cohort, almost 300 NEOA patients are very extensively characterized with the specific purpose of being able to define, to detect different phenotypes in this population. These patients are followed up for 2 years, and this table shows the extensive data that are collected from these patients on many domains, on the knee joint itself, but also on other joints. It also directly shows the limitation of this approach. How can we translate this into clinical practice? We will not be able to do all these exams in a regular routine patient. So that will be a next challenge, how to translate findings from this trial in clinical practice. Another challenge is that this is a huge effort. I'm involved in this myself. I know how much work this will cost, but still the population size is quite limited for phenotype research. 300 patients is a lot of work, but for doing phenotype research maybe is a little bit limited. So more rare phenotypes might not be picked up in this approach. And another thing is, which I didn't explain yet, but these patients have been selected from existing cohorts and have been selected for a high chance of progression during the time of follow-up, which also means that translating the findings from these cohorts to a general OA population, the population that will arrive in our offices, is also not very straightforward. Phenotypes with lower rates of progression might be missed in this approach. So it's very important to realize that the population you select will determine the phenotypes you will find. And that's very important in comparing results between different cohorts. Another approach is to perform trials in anticipated OA phenotypes. A much reported inflammatory phenotype is the phenotype of hand OA. And one nice example of that is the HOPE trial. In this trial that was recently published in a Lancet journal, of course, they selected patients with hand OA defined by the presence of osteophytes, but they also only selected those patients with clinical signs or ultrasound signs of inflammation. And only in these patients, they tested the effects of prednisolone, 10 milligrams a day for 6 weeks. And in these patients with inflammatory characteristics, indeed, prednisolone was able to reduce pain. And after quitting the treatment at 6 weeks, pain increased again until the level of the pain in the placebo group. It's questionable if the same results would have been reached if this trial was just performed in a general hand-OA population without selecting these particularly inflammatory patients. Another example is the bone phenotype, let's say. Lots of attention has been raised by a landmark study by Laura Leslet and colleagues from Tasmania, showing that in Neo-A patients in the presence of bone marrow lesions on MRI, zoledronic acid, a single gift, so an anti-osteoporosis drug, was able to reduce the size of the BML in these patients, and with that also reduce pain in these patients. So indeed, suggesting that this subgroup of patients, so Neo-A patients with BMLs, might be a bone phenotype subgroup that is susceptible to anti-osteoporosis drugs. This small study with a single gift was followed up by a larger study, a multi-center study by the same group, with 2 gifts of zoledronic acid at 0 and 12 months. And unfortunately, on top, you can see that BML size this time did not decrease with zoledronic acid treatment. Also, pain, according to the FAS and according to the WOMAC, was not reduced in this trial by zoledronic acid in the same population. This data have been resulted quite recently. So by then, other trials are also still going on and results will come up over the next years. And one of them I'm involved in myself is the Zodiac Trial in the UMC in Utrecht in the Netherlands, giving patients with Neo-A and BMLs zoledronic acid, this time 4 times every 6 months, with the primary endpoint of cartilage thickness in the knee on MRI. So, although I think at first enthusiasm about this bone phenotype was bigger than nowadays by the disappointing trial from the group in Tasmania, I still think this is an interesting group, and I still read many publications on the potential of this subgroup. I'm very eager to see, very curious to see where this will go. And of course, there are many more examples, but I would like to go on to another approach. For example, performing post-hoc analysis in trials. A trial you all might know is the trial, a phase 2 trial of loracivivent, a Wnt inhibitor that's been tested for Neo-A. And in this trial, long story short, in the intention to treat population, the drug was not able to reduce pain clinically significantly. However, if they looked in a subpopulation with patients with only unilateral knee pain, effect sizes increased. Also, confidence intervals increased because numbers were lower, but still, this suggests that pain might be different between the group as a whole and in this unilateral knee pain subgroup. And with that, also, the effects of loracivivent might be different in this subgroup. Effect sizes increased even more when they selected only those patients with unilateral knee pain again, but also without widespread pain. So maybe loracivivent is especially useful for people with local pain without central pain sensitization. And I'm again very curious to see how this will impact future trials and if this can be shown again. Interestingly, not only pain reduction is different between the subgroups, also the effects on joint space loss or joint space width are higher in the unilateral knee pain group and the group also without widespread pain, which is a thing I don't really understand yet, but maybe not only the pain systems differ between these groups, but also the mechanisms of cartilage damage might be different between these groups or phenotypes. I would just like to shortly go back to the HOPE trial, the prednisolone for inflammatory hand OA trial, and show data that were presented at the recent ACR. Again, on the bottom figure, the authors show that pain was reduced at week 6, but if they just looked at neuropathic pain as measured in the pain detect score, a questionnaire, they didn't see this positive effect. So neuropathic pain, as could be expected, doesn't respond to prednisolone treatment. So residual pain in patients treated with prednisolone or people non-responsive to prednisolone might be patients that would also benefit from treatments directed at neuropathic pain. So again, I'm curious to see where the field of neuropathic pain will go. There's a lot of interest for that. And this might, again, benefit this particular subgroup or maybe pain phenotype in hand OA. Some challenges are, as I've shown you, that phenotypes might overlap. That might be challenging in research, how to select the right patients for the trial. Can they also have other phenotypes? And should we investigate these patients for all the other phenotypes and how to do that? And also in clinics, should we treat a particular phenotype over another phenotype, or should we treat them all at the same time? Which are things that still require more research once we know more about phenotypes. Another challenge I might think of is that phenotypes might change over time. Phenotypes might differ between disease stage. So should we investigate patients every time again for the presence of a particular phenotype? And should we adapt treatment to that all the time? And as I mentioned in the approach trial, how to translate data from research to clinical practice. If we need very advanced, difficult, or expensive techniques to detect a phenotype, that might still limit the impact this knowledge might have in clinical practice, which is, of course, in the end, what we're doing this all for. There are many more challenges, and maybe we can discuss them later, but I would limit myself to these. With that, I would like to thank you for your attention and your input, of course. I think it's time for discussion, to think outside of the box. And so Ali is also here. I would also like to share with you this call for papers on high throughput omics technologies for deep phenotyping in osteoarthritis, which is of course related to this topic. And I'm already looking forward to this themed issue. So with that, I would like to conclude. Yeah.
I just wanted to say thank you, Erwin, for that was really excellent. I've been looking forward to this, and I hope we have just 2 minutes left for questions here. And while people are typing something into the group chat, I just want to ask you a question that I've been looking forward to all day, because we have a lot of smart people on this symposium. And one of my favorite papers is actually David Felson's, that OA is a state of inertia followed by periods of progression. And so if we are thinking of these phenotypes, I mean, how long time do you think they are there? And is it possible actually to do a clinical study on these phenotypes if a phenotype changes during a clinical study?
Yeah, that's a very good question. And that's one of the challenges I also noticed myself. I think if the outcome measures are specifically aimed at that particular phenotype, you might still test the effects of the treatment on that phenotype, maybe. But yeah, it will complicate the picture for the treatment response as a whole. I don't really have the answer yet on your question.
It was an evil question. That is what it was.
And you're looking forward to it. So.
while others are waiting. So I noticed, of course, and I've been so lucky that you forwarded my presentation or your presentation, Erwin. I appreciate that. And so in the solendronate study you are doing, I'm sure you're aware that the study is done in also OA population of Procter & Gamble with a bisphosphonate. And there was actually some biomarkers that were able to find the ones that actually were progressing. So have you actually been enriching for molecular endotype in that study? Of course, I'm going to ask about TTX2, and you knew that, but are you selecting for some of those molecular endotypes?
No, we didn't. Because the inclusion has been going on for quite a long time, and has also been extended because of the Corona crisis. So that was one thing. We couldn't be too strict on selecting subjects, and also the knowledge back then when we started including was not there yet. But I definitely think it would be a worthwhile addition to our selections. But we didn't do that. Yeah.
I think there's a bone phenotype, and I hope you'll find that bone phenotype, and with an anti-resorptive, that's important for me.